Today we are going to review cardiac point-of-care ultrasound from the perspective of bedside practicality. The goal is not to replace formal echocardiography, but to understand what focused cardiac ultrasound can do well, what it cannot do well, and how to acquire the key views reliably enough to answer urgent clinical questions. Starting off, one of the biggest reasons cardiac pocus has become so useful is standardization. When we use standard views, standard language, and a standard acquisition sequence, the examination becomes more reproducible, easier to teach, and safer to interpret. Standardization is what turns pocus from a casual scan into a disciplined bedside tool. The cardiac ultrasound spectrum spans different modalities. On one end is focused cardiac ultrasound, which is a quick, targeted, and problem-oriented. On the other end is a comprehensive transthoracic echocardiogram, which is broader, more quantitative, and designed for full structural and hemodynamic assessment. Knowing where your study sits on the spectrum is critical because scope defines what conclusions you should and should not make from your examination. The basic pocus is a focused bedside examination used to answer limited clinical questions. It helps assess ventricular size and function, gross chamber relationships, pericardial effusion, major hemodynamic clues. It is not intended to fully quantify valvular disease or replace a formal echocardiogram when a complete study is needed. There are 5 core views of focus. The core focus cardiac views are parasternal long axis, parasternal short axis, apical 4-chamber view, subcostal 4-chamber view, and usually the subcostal IVC view. For this session, I want the residents to focus on mastering acquisition first. If you can consistently obtain these windows, interpreting them becomes more reliable. The parasternal long axis view. We usually begin with a parasternal long axis view because it's an excellent orientation. The patient should be in the left lateral position, lying on the left side with the left arm tucked under the head. Place the transducer in the 3rd or 4th intercostal space at the left parasternal border with a marker pointed towards the patient's right shoulder around the 9 or 10 o'clock position. In a good parasternal long axis image, left ventricle should appear horizontal, aligned with the ultrasound beam. The true apex is usually not seen. So if you think you're seeing an apex, consider a false apex, correct with a small tilting, angling, or rotational adjustments. If the ventricle does not look horizontal enough, move to a higher window or roll the patient further to the left side. To optimize the image, place the mitral and aortic valve in the center by tilting the probe slightly away from the sternum. Rotate gently until the aortic cusps appear symmetric. In this view, you should be able to identify the left atrium, the mitral valve, left ventricular outflow tract, aortic valve, right ventricle, interventricular septum. Parasternal short axis view. It's obtained by rotating the transducer 90 degrees clockwise from the parasternal long axis view. Now the marker points towards the patient's left shoulder around the 2 o'clock position. Beam becomes perpendicular to the long axis of the left ventricle. For the aortic valve level view, tilt the transducer superiorly and medially while keeping the marker pointed towards the left shoulder. The goal is to place the cross-section of the aorta just above the valve in the center of the image. This view allows the visual assessment of the aortic valve, right ventricular outflow tract, pulmonary artery, pulmonary valve, tricuspid valve, and interatrial septum. The key teaching point is that it is not just a rotated image, it's a different cross-sectional way of looking at the heart. In a beginner, the most common error is losing the aortic root in the center or drifting off axis. Small tilts and small rocking movements are usually enough to recover the correct view. Apical four-chamber view. Place the transducer at the palpated apical impulse, usually in the fifth intercostal space, with a marker at about 3 o'clock. In the correct apical four-chamber view, all four chambers should be centered with the left-sided structures on the right side of the screen. Right-sided structure on the left side and the apex at the top center of the sector. Interventricular septum should appear vertical and parallel to the ultrasound beam. If it is slanted, move the transducer slightly medially or laterally until the septum becomes more vertical. You should see both mitral leaflets and two tricuspid leaflets. If the ventricles appear too round or spherical, it usually means the view is foreshortened. So move the transducer 1 inch space lower to recover the true apex. To better show the atria, tilt the probe anteriorly. The aortic valve should not be seen in the true four-chamber view. So if it appears, tilt the probe posteriorly. The subcostal four-chamber view is the rescue window. It is particularly useful when the parasternal or apical views are poor. Place the transducer beneath the xiphoid, slightly to the right of the sternum. Push the probe down and direct it towards the patient's left shoulder. Sometimes if the patient breathes in, it helps. The index marker should point towards the patient's left side, again around 3 o'clock. All four chambers should be visible, with the right-sided chambers closest to the probe and therefore at the top of the image. The entire left ventricle, including the apex, should be shown, and the aortic valve should not be visible in the correct subcostal four-chamber view. This is a very important view for assessing the interatrial and interventricular septa, especially if the quality is poor in other views. It is also one of the best bedside views for identifying pericardial effusion, which appears as a separation between the pericardium and epicardium. These images are courtesy of the website that's indicated in the bottom right. Targeted scenarios. Once these views are acquired well, they can answer very practical bedside questions. Is the left ventricle severely depressed? Is the right ventricle enlarged? Is there pericardial fluid? Are the chambers grossly disproportionate? Is there an obvious large regurgitant jet on limited color Doppler? The value of cardiac pocus comes from matching the image to the clinical question. A good acquisition checklist keeps you disciplined. First, identify the window. Second, confirm the marker orientation. Third, center the target structure. Fourth, optimize the depth gain and sector width. Fifth, make sure the image is anatomically correct before you interpret it. In other words, acquisition quality comes before diagnostic confidence. In advanced cardiac pocus, it goes beyond basic view acquisition and gross pattern recognition. It may include more detailed hemodynamic assessment, more complex valve screening, more nuanced integration with the patient's physiology. But advanced applications only work well when the operator already has strong control of the core windows. It is equally important to know the boundaries of transthoracic imaging. Not every structure is well seen from every window. Not every pathology can be confidently ruled in or ruled out with focus ultrasound. You should learn what good judgment includes, recognizing when the exam is limited and when formal echocardiography is needed. The blind spot of pocus includes LV apex and pericardium. The left ventricular apex, particularly when the apical view is foreshortened, is one blind spot. A rounded ventricle can hide apical pathology such as thrombi and distort true chamber shape. This is one reason why careful acquisition matters so much. Same is true for pericardial fluid, where an off-axis image may mislead the examiner. Another blind spot is the aorta and the coronaries. Another limitation is the aorta and coronary arteries. Focused cardiac ultrasound can sometimes suggest abnormality, but is not designed for full aortic and coronary assessment. You should be careful not to overstate what cardiac focus can conclude in these areas. Another blind spot is extracardiac structures. Cardiac windows also intersect with extracardiac structures such as pleura, lungs, liver, mediastinal tissue. These can help or hinder the exam. For example, the liver is actually useful in the subcostal view as an acoustic window, but extracardiac findings can also distract the learner if they are not recognized properly. The pocus ecosystem is part of the whole cardiac ultrasound spectra. Cardiac ultrasound works best when integrated with lung ultrasound, venous ultrasound, physical examination, hemodynamics, overall clinical picture. It is not a standalone trick. It's a bedside extension of reasoning. The key take-home message is simple. First, know the scope of cardiac focus. Second, master the core views before trying to make complex interpretations. Third, use standard acquisition techniques every time. And finally, respect the boundaries of the modality. Good cardiac focus begins with good acquisition and ends with good clinical judgment. Thank you for watching. More to follow.